Good afternoon, everyone. I'm Amy Dezern speaking to you from Baltimore, and I'm really pleased to have the opportunity after the nice morning you've had to give you a quick update on bone marrow transplant for both aplastic anemia and MDS in the current era. So this is obviously a large topic, as the others you've heard are, but what I really hope to show you is that we really think about who we transplant in these conditions with a goal of minimizing short and longer term complications of both conditions. And certainly consideration for path to cure is an important part of this. So let's first talk about aplastic anemia, and then the second half of our talk will be about myelodysplastic syndrome. So currently, as you heard from some of the other speakers, this is the standard clinical algorithm for aplastic anemia. But we always go down that path of, does someone meet criteria of being quote unquote young and having a fully matched sibling, or do they not? And that usually shunts us down the therapeutic path initially. And then we have to think about where we need to intervene based on the clinical follow-up thereafter. Immunosuppressive therapy, as you've already heard about, is typically reserved for patients who are quote unquote old, and I fall in this age category, so that is not intended as any sort of negative, or children who don't have a full sibling, but it's not a path to cure. And transplant is increasingly something we think about in aplastic anemia, not just for younger patients or children who have full siblings, because it is that path to cure. Understanding the longer-term complications of immunosuppressive therapy is something that the entire aplastic field has been thinking about for a while. And I often think about this particular paper because it's long follow-up European patients of a clinical trial of immunosuppression. This did not include eltrombopag, which is, I know, something you've just heard about, but it's longer-term follow-up because it's more mature data. And the event-free survival is something to focus on, and that's why we're increasingly changing how we think about transplants specifically for aplastic anemia, getting to the point of this particular program, making it more accessible to people and also making sure it's safe. Excuse me. So I mentioned that if you're young and you have a matched sibling, we're really trying hard to use transplant. That has been the standard for 40 years. And that will always be the standard by which we measure, in general, the matched sibling transplants. So I refer you to some fairly contemporary data, at least in the 2000s, about matched transplants, both related and unrelated. And this was a study that was a retrospective report from the Center for International Blood and Marrow Transplant Research, but it was really multi-center, and it was looking at those matched type of data that we need to think about. A large number of patients in one place for engraftment, chronic graft versus host disease, and overall survival. And these are what we're trying to think about when we look through newer transplant platforms. We need engraftment of over 85% in less than 3 weeks from the day the transplant goes in. We need as low rates as feasible of chronic GVHD, because we certainly don't want to exchange one problem for another. And then we obviously want to really make the event-free survival as fantastic as we can, and that includes overall survival. This type of data also gives us important longer-term understanding of some of the late effects. We have to think about secondary malignancies sometimes, or fertility. So really today, in terms of most innovation in recent years, I want to talk to you about alternative donor transplant. This has not always been part of the algorithm because of concerns about complications, but increasingly alternative donors, mostly people consider those half-matched transplant donors, but it may also be unrelated donors, are coming earlier and earlier in our transplant algorithm. And that's partly because of regimens like this. I'm showing you some of our internal data, and then I'll show you multi-center data, because this is really where the field is. We use rabid ATG, cyclophosphamide and fludarabine in the conditioning. We also use total body irradiation, and we now know we need a little bit more than we originally thought in terms of dose for the radiation on day -1. We always use a bone marrow graft because in aplastic anemia, bone marrow stem cell source is associated with less graft versus host disease than peripheral blood stem cells. And then a really important part of being able to use a mismatched donor like a haplo or even someone not related to the recipient, is really strong graft versus host disease prophylaxis with post-transplant cyclophosphamide on days +3 and +4, as well as mycophenolate or CellCept and tacrolimus to about day 180. So I'm just going to show you some data internally of the patients we've treated here. This used to be considered somewhat of a questionable approach, but now we use it for all of our patients. And we used it in both the relapsed and refractory setting, and we use it in the upfront untreated setting, which is increasingly where the field is going, more away from immunosuppressive therapy, if you think like a transplanter. We've treated even more patients than this now. These are the mature data, but the take home from this slide is that we can treat adult and pediatric patients like this. We can treat males and females like this. We can treat people of different ethnic backgrounds, and we can also use a wide range of donors. And that's really probably the bringing equitable and accessible care to patients, why this platform is so important. It's very gratifying, back to what we use as the measuring stick, that matched sibling transplant, to have neutrophil recovery in less than 3 weeks. This diminishes some of those infectious complications and is really important for getting the counts back in. You can see the neutrophils come back first, but the red cells and the platelets follow thereafter. Certainly, transplant comes with toxicities that are different than immunosuppressive therapy. We've learned a lot over the last 8 years that we've been doing this quite intensively. We have had complications in both the relapsed and refractory and treatment naive setting, but you heard me mention on the slide for the algorithm that we now use 400 centigrade of total body irradiation, and that's really to minimize any of the infection, failure to engraft, or unfortunately mortality complications of this procedure. And we have not had any of these issues since we've been using the higher amount. I talked about not exchanging one complication for another, and this particular regimen in our hands has extremely low rates of both acute and chronic GVHD, and these are the curves to show you. Nothing is zero, but I can tell you honestly, these are not life-limiting rates of GVHD in any way, and these patients are still able to come off all immunosuppressive therapy, usually by 18 months and certainly by 2 years, which is very important for lifelong healthcare-related quality of life, and certainly for other complications. And what you can see here is we have excellent overall survival. And when we use 400 centigrade, now that we've really fine-tuned the regimen, we're sitting at 100%, and this continues to be the case. So the overall survival for all patients is really very gratifying, and it compares favorably right now to the phase 3 trial you may have heard about with horse ATG, cyclosporin, and eltrombopag. So that makes transplant using the best available donor really something to think about in aplastic anemia in 2022. And in case you were wondering if this is only applicable to living in Baltimore, that wouldn't really be in keeping with our goal for equitable care for all. I'll quickly show you some results that were published this summer of a multi-center BMT study across the United States using the regimen that was developed here prior to the augmentation of 400 centigrade, and we had very similar results. Again, the small trial, this group knows as well as any, this is a rare disease, but we were able to treat patients, pediatrics and adult, and also those of quite a varied ethnic and racial background, which is so important in the current era. We had adult and pediatric, as you can see, and then these are the patients based on their background. And this is more than 40% of people who are non-white. And that's really very important as we think through who we're trying to help with this condition. The overall survival, again, very favorable. This was a heavily relapsed and refractory population at 200 centigrade for the total body irradiation, and the patients are doing very well. There were some early deaths, and this study also helped us realize how important that bone marrow harvest is to make sure all patients get the best graft possible. All right, I'm going to quickly switch gears to MDS. This is a short talk, and there's a lot more complexity in actuality to transplant for MDS in some ways than there is for aplastic anemia. but we still want to think about it in terms of that short-term and longer-term goals for our patients. The reality in the current era is that most MDS patients still don't go forward with transplant. We really have to think about it in terms of upfront therapy, managing toxicity, and how we're thinking about transplant. This has a lot to do with the age of MDS patients in particular, but we here don't have an upper age limit per se of transplant. We just always want to think about balancing the risk of the disease the patient has with the risk of any potential therapy that we choose. So it is so individualized. And getting back to the comment earlier about a path to potential cure, that's true for aplastic anemia and for MDS. I will be candid that it's probably easier to cure aplastic anemia than it is to cure MDS with transplant, but possible in both arenas. There's a survival benefit to transplant for MDS, and I'm going to show you some very recent data that really highlights that. Something that the transplant field has worked on for a while is what the optimal point is for transplant in the course of disease for a patient with MDS. Because while cure sounds very delightful for anybody, we want to make sure that we're using a therapy that has side effects and toxicity at the right point for an individual patient. As I alluded to, age as a number is not a contraindication to transplant, but we really have to think about the whole patient, organ function, frailty, and other ways in which transplant needs to be feasible to make it a safe plan. The other difference is there is a wider variety in many centers of the flavor and type of transplant that we can offer to a patient. And I list this here in the third bullet that's big about dose intensity. And this has a lot to do with relapse risk as well as toxicity from the therapy. You may have heard the words maxi and mini used to describe transplant, particularly for MDS or leukemia. And we really have to balance the risk of relapse with the risk of the transplant itself. The prognosis and the potential for cure for a patient with MDS after a BMT has many features that go into it. Certainly, we have to think about relapse or recurrence risk, and that depends on the flavor of MDS, how under control the MDS was, what was that status when a patient went to transplant, how long they'd had their disease before that. And we're increasingly in the MDS community in particular, using molecular information to risk stratify and understand specific biologic phenotypes of MDS, which we transplant more or unfortunately less successfully depending on that disease biology. Certainly the risk of GVH depends on a number of things. That's true in aplastic anemia as well, but donor type and match, and all the things that go into that for potential infection and performance status and other health issues that somebody who has MDS may have. The average age at presentation of MDS right now is around 70, and that's a number more of years to develop other healthcare problems that we need to think about. So this is kind of the way I think about what we're balancing in terms of risk of a non-transplant therapy for MDS, and then the risk of having a successful outcome or the benefit of transplant. There's no hard and fast numbers for some of these. The IPSS is something we use less, but it's actually what's been studied in the literature the most in terms of transplant. We now have the International Prognostic Scoring System revised, and as of this summer, we have the International Prognostic Scoring Molecular, and we're still learning how to factor those things in. But certainly if someone is very high risk, I'm going to show you some transplant data that really suggests not doing a transplant probably is not the best thing. And so we need to balance it. Whether or not somebody has treatment-related disease continues to be an issue. If someone does not respond to a hypomethylating agent like azacitidine or decitabine, that's a pretty big effect if you don't use transplant. We've talked about molecular abnormalities. Some of you may be familiar with the hematopoietic cell transplantation comorbidity index, and that's a way to plot in a numeric fashion a patient's other healthcare problems. And sometimes the outcomes are diminished the higher number of points we get on that scale. Performance status is a little subjective, but it's also a pretty good surrogate for how strong a person's body is to go through this type of therapy. There's been a lot of people who've done excellent and scientific approaches to geriatric assessment for MDS in general, as well as for transplant. And then there's a prognostic score specifically related to a patient's disease that also can impact how likely a transplant is to help. So this is just a very tabular way of saying it's so individualized, and that's really the most important thing. We know that patients who get initial therapy for higher risk MDS still don't have a cure from azacitidine or decitabine. And so the further months they are after initiation of that treatment and from diagnosis, the less well we do, even if they have an initial response from those therapies. And so this is just some survival curves by a colleague who were really looking at the non-transplant approach and if we need to think about going to transplant for patients with high-risk disease, because this might be the alternative. The BMT-CTN, again, the transplanting body in the US, did a very nice study that was published not quite 2 years ago. It'll be 2 years in the spring. And these are some survival curves. And this looked at a reduced intensity transplant. So that gets back to that intensity of the transplant treatment with a fully matched related or unrelated transplant compared to best supportive care in patients who were quote unquote older. So this is in their 50s and 60s to go to transplant. These were all high-risk patients by the International Prognostic Scoring System. And what this trial showed very concretely is that overall survival is improved by having a donor, and the time to get leukemia or leukemia-free survival is also better when you have that donor. This is also true when you go to transplant. That sounds a bit confusing, but it's because you can't really randomize a patient to transplant or not. That's not always in keeping with our trial principles. So this is in many ways a biologic assignment trial that did not include alternative donors like we just talked about with aplastic anemia, but it really shows that the consideration of transplant, having a donor, and getting to transplant if a patient has higher risk MDS is of benefit in terms of longer life and not getting leukemia. And so that was quite the important take-home point from the BMT-CTN 1102 study. So even though these issues remain somewhat controversial, we have to keep thinking about it. And prior to that, these trials were lacking. Now I'm going to show you some additional data from Europe called the Vidasa-ALLO study, which is similar, though not analogous, to the trial I just showed you from the BMT-CTN. But this has a little bit different age group. But again, it's the higher risk MDS patients. And what it looked at was transplant, again, reduced intensity, after 4 to 6 cycles of azacitidine, that initial therapy. And again, looking at survival for patients that had a transplant or those who kept getting azacitidine. They looked at event-free survival. An event is getting leukemia, other side effects, and then actual complexity from the transplant like death. This set of survival curves do not clearly split quite as much as the ones I just showed you from the BMT-CTN trial, but I really tried to show you in this particular panel on the right that overall in higher risk disease, we still favor transplant. And there's probably some statistical reasons, as well as the fact that this was looking at people who were continued rigorously on azacitidine, that these curves don't separate quite as much. But even still, transplant was favored for higher risk patients here. And this is an important thing to think about if you or a loved one has a diagnosis of higher risk disease. So in our very few minutes together today, I hope I've shown you that transplant is always an option for aplastic anemia or for MDS. In aplastic anemia, we're using any donor now. It's very useful for relapse disease. It's also very useful, we now realize, for treatment-related disease. The overall survival really seems improved, perhaps even compared to immunosuppressive therapy. We've known that for years with matched sibling donors. It's increasingly accepted for matched unrelated donors and half-matched donors. That disease-free survival is very important, and we're going to keep learning the longer these platforms are available about secondary cancers or fertility issues, which are important. I'm pleased to tell you that half-matched transplants for aplastic anemia are about to open in the BMT-CTN forum based on the data that I showed you from internally. So really, every patient could have an option for transplant, certainly at the relapse setting, but also in the upfront setting, even if it's with a half-matched donor. There's a randomized trial ongoing in pediatrics comparing transplant with immunosuppressive therapy, again, to try and learn about using a matched unrelated donor upfront for younger patients. So a lot of good area for investigation there. In terms of MDS, the two studies that I showed you in higher risk disease were with matched related or unrelated donors. Haplos are an option there as well, just to know. Age alone is not a contraindication. We do favor transplant for high-risk MDS. We don't do it necessarily if somebody is lower risk. Doesn't mean it's not good to get a transplant consult or things like that, but we do just have to think about the risk of the disease versus the risk of any therapy. And that's why the data usually shifts that bent to higher risk disease. And that's why those trials were designed as they were. Usually in patients who are over 50 or 60 into their 70s, we do use that reduced intensity regimen. This may come at the expense of higher rates of relapse. We're still refining our regimens, just as we did in aplastic anemia, to try and make this better. So think about all these options. I'm happy to take questions, and I'm grateful to the team here and with AAMDS and otherwise as we work towards improving outcomes and transplant for both conditions for all patients so that everybody can have access to this potential path of therapy. Thanks so much for your time.
Thank you, Dr. DeZern. We do have a question from online. Is there any preference cutoff on haplodonors' age in aplastic anemia or MDS transplant?
So it's certainly very individualized, and we have quite careful metrics for the eligibility of a donor, as technically they are normal. So it is usually not about age, but some other factors. Sometimes there's a weight requirement, but we have used children for adults. We have used children for their siblings. It just has to be assessed based on size in part in the transplant center.
And with the various trials that you mentioned, is that something that patients should inquire about also if they're not receiving information about transplant options?
I do think in both settings, referral to a transplant center has merit. I recognize that's not always easy for a number of practical reasons, but asking the question, and I'll just say, just this morning in clinic, I saw someone who absolutely does not need a transplant, but it was a very fruitful conversation, I think, for them and their family to know that the option is there, but not needed. And sometimes that really does take somebody with transplant clinic in a center that does them to answer the questions concretely. So a patient should always feel comfortable to ask for a referral to a transplant center.
Don't have any further questions at this time, so we can go ahead and you can conclude your presentation and refer on to the panel discussion next. Thank you, Dr. DeZern.
Best to all.
Hello, everyone. I am Nandita Khera, a blood and marrow transplant physician at Mayo Clinic, Arizona. And I'm accompanied today by Dr. Linda Burns, Senior Scientific Director, CIBMTR Milwaukee. And we are glad to be here today to talk to you about reducing barriers to transplantation. We have no disclosures. For the first part of the discussion, I would be talking to you about some of the patient and provider perceived challenges in access to hematopoietic cell transplantation, or more commonly known as bone marrow transplantation, and then highlight a few things that we think are important to overcome these challenges to expand access to transplant. Dr. Burns, in the second part of the discussion, will talk a bit about organizational initiatives to reach underserved patient populations. And these organizations include Blood and Marrow Transplant Clinical Trials Network, the American Society for Transplantation and Cellular Therapy, and the National Marrow Donor Program. So let's start by talking about some of the patient-perceived barriers to transplantation. So we recently got a diverse group of stakeholders together to understand what these challenges are from a patient level and a provider level. And this was done in response to trying to understand how we could improve the uptake of bone marrow transplant for myelodysplastic syndromes, as a recent large study showed superior outcomes with transplant as compared to non-transplant for high-risk MDS patients. So some of the challenges that our panel felt are important from a patient standpoint are as follows. Perceptions about high risks of transplantation without being put in the context of benefits, especially if that discussion is held with a hematologist who is not a transplant doctor. Social barriers, you have probably heard of the term social determinants of health. Neighborhood, environmental factors, education, employment, all of those factors, including cultural conceptions, are important also in or can serve as barriers to transplantation. Logistical challenges are very important, as patients may have problems arranging transportation and lodging benefits, or a caregiver who is supposed to be an important part of the transplant journey. Lack of insurance coverage may be considered a barrier, especially if it is suboptimal, especially in the post-transplant period. And finally, from a medical standpoint, lack of optimal donors may be perceived as a challenge by the patients. However, our field has progressed to a point where we should have a suitable, even though they may not be a full match or anything, but we do have suitable donors available for most of the patients that need transplant, with the increasing use of alternative donor sources such as half-matched transplants or cord blood, or even different techniques using very highly mismatched unrelated donors. From a physician standpoint or provider perspective, some of the challenges that our group thought were important were lack of awareness of the process and the progress our transplant field has made amongst the community hematologists, oncologists. Sometimes there may be concerns about potential revenue loss if they refer the patient to a transplant center and the patient decides to stay there for their treatment. Lack of care coordination, both at the pre-transplant and the post-transplant end, was felt to be a barrier, again, by the community hematologists, oncologists, and especially the fact that there is sometimes lack of clarity on post-transplant care and the roles and responsibilities towards the patient at that time. Financial barriers are again very important. There may be need for in-network insurance, and all of that may play out into delaying transplant referrals for patients. So how can we as providers help overcome some of these challenges to access? The first and foremost thing we can do is education. We can educate the patients about all possible treatment options, whether it's transplant or non-transplant, and extensively discuss the risks and benefits of the approaches. We can improve access to the transplant for all eligible patients via certain techniques such as use of telemedicine. We all know telemedicine has expanded a lot during the pandemic, and it can help us reach patients who are remote or are in a rural area to be able to at least get that first consult with a transplant doctor. We can partner with referring oncologists to ensure that there are early referrals done for transplant consultation, irrespective of how the oncologist feels about the candidacy for transplant. We should let the transplant team decide whether a patient is an appropriate candidate or not. And finally, we can help develop strong psychosocial support systems and infrastructure, not just to work on the front end with rehabilitation and social support for our older patients. Again, age is a main barrier for transplant sometimes, but also make sure that we can provide optimal post-transplant care to help improve both access and outcomes of the transplant. So how do our patients and caregivers obtain information? Because again, information is something that can help overcome these barriers at multiple levels. They can speak with their doctor about the disease if a transplant might be an option, either in the current time or in future. They should be prepared at the transplant center meetings to ask questions about their disease and support needs. And finally, there are a lot of professional society websites that offer very rich information about the process of transplant, the medical and the psychosocial complications. And some of the examples would include NMDP Be the Match or BMT Clinical Trials Network Program and Aplastic Anemia MDS International Foundation. So with that, I will hand it over to Dr. Burns. Thank you.
Well, Dr. Kara, thank you. Before I start on my presentation, I have a couple of questions for you, if I may. You highlighted both patients and providers as the main players in addressing barriers. Who are some of the other stakeholders that you think play an important part in this process?
I do think there are a lot more stakeholders involved in this process, Linda, Dr. Burns. Payers are very important, whether it's private insurance companies or CMS, which is Center for Medicare and Medicaid, to be able to make sure that we have optimum coverage for transplant and for clinical trials under the transplant area. Another important stakeholder, as I mentioned, for the information piece is these professional societies and patient advocacy organizations that can not only help increase awareness about some of the latest advances in the field, but also help provide information that the patient about resources that the patients may need to be able to come to transplant and go through the process.
Well, you're a very busy and active transplanter, and I know that you volunteer quite a bit of your time also for improving access. And as part of that, you've been working on a project with other physicians in the Health Services Working Committee at the Center for National Blood and Marrow Transplant to look at improving the use and outcomes for patients of racial and ethnic minorities over the past few years. Could you share some findings of your project with us?
Sure. I am very proud to be leading this project at the Health Services Working Committee at CIBMTR, where we tried to assess the changes over time for different racial ethnic groups in terms of utilization and outcomes of transplant. So we looked at three main groups, non-Hispanic whites, African Americans, and Hispanics over the years 2009 to 2018 to assess how utilization has changed for these groups and how the outcomes. And in general, we saw that overall things had improved, both in terms of utilization and outcomes for everyone. However, we found that the African American patient population was still somewhat suboptimal utilization for allogeneic transplants, as well as for the outcomes. Even though adults, African American adults did okay, comparable to the other groups, in pediatric patients, we found a major gap in terms of outcomes between the African Americans and the other groups. Hispanics actually have done quite well in terms of both improved utilization and outcomes over these years, indicating that there is definitely progress in the field. So just remember, though, this is a quantitative study, and all it can tell us is this quantitative data that we need to then explore further through maybe qualitative studies and more extensive exploratory studies to understand what the factors are for these findings, responsible for these findings.
Well, thank you very much. And with that, if you'll turn to the next slide, I'll begin the second half of our presentation.
Okay, thank you.
I'm going to be speaking about some initiatives that are trying to reach underserved populations. And as Dr. Kara mentioned at the beginning, I'm going to talk about two major initiatives, one by the Blood and Marrow Transplant Clinical Trials Network, or BMT-CTN, that I'll tell you about here in just a second, and the other by a collaboration of our professional society within the United States, known as the American Society for Blood and Marrow Transplantation, or ASTCT, along with the National Marrow Donor Program. Many of you may be familiar with NMDP, which serves as the large volunteer organization to identify donors for patients of need of a transplantation. So the next slide, we'll start by speaking about the Blood and Marrow Transplant Clinical Trials Network. And this is a presentation that's been given at the national level and will be published from Dr. Mary Horowitz and her colleagues, looking at how this network has done in enrolling patients of underrepresented groups on its trials. And the bottom line is shown here, and the punchline is we can do better. So on the next slide, I'm going to tell you a little bit about the network. So it was established 20 years ago. And since 2003, over 125 centers, primarily throughout the United States, with a couple of centers in Canada, have enrolled over 16,000 patients on trials. And these trials are typically done with multiple centers being selected to join together to enroll as quickly as possible patients to achieve an understanding of the best types and ways to perform transplantation to improve our therapies and save lives. So on the next slide, I'm going to walk you through this, so don't be intimidated by it, but I think we'll be able to make our points. So what the network did is they looked back at the last decade of the trials that they have performed. And across the bottom, trials are numbered by when the study became a priority study for the network and began ultimately as enrollment. So 1301 meant that study concept was developed in 2013. And on the right-hand side, 1704, that study began in 2017. On the left-hand side, in a column, are the percentage of patients from groups other than non-Hispanic white, so underrepresented groups. And that yellow line at 40% represents the percentage of patients from these groups in the population of the United States. Now, each study has a particular objective. So for example, 1301 was focusing on graft versus host disease, a complication that can occur from an allogeneic or using a donor that's not yourself. 1302 focused on myeloma and so forth. Now the black line at the bottom shows the percentage of patients from groups, underrepresented groups that were enrolled onto that study. The purple line represents the percentage of eligible patients at those centers that were participating. And then the light gray line, the eligible patients in all the United States transplant centers. And you can see that in almost every study, the number or proportion of patients that were enrolled on the clinical trial was less than was projected, did not meet even the targeted enrollments, except for one. You see that one in the middle? That was BMT-CTN study 1502. And for those of you who were present for Dr. DeZern's talk, that this is the one she discussed that really has moved forward the care for patients with severe aplastic anemia. And this was a study looking at half-matched or haploidentical, so you don't need a fully matched donor for severe aplastic anemia. And you can see that it was even above the percentage of patients from groups other than non-Hispanic white in the US population. And the thought is that we know that patients from underrepresented groups have difficulty finding a perfectly matched donor through the National Marrow Donor Program. A proportion of patients that have a perfectly matched SIB is less than almost 1 to 4 in the current day and age. And so we really rely on the National Marrow Donor Program to find unrelated donors for us. And within the registry, underrepresented groups are smaller than we would anticipate. So this really opens up access to transplantation using a half-matched donor. So on the next slide, I'll tell you a little bit about what the network is hoping to do. And so they have some strategies that they're planning and will be monitoring carefully to enhance diversity. So from the very beginning when developing the protocol, that they're going to collaborate with patients, patient advocacy groups, professional societies such as AAMDS, to really hear the patient voice. and what patients feel will be most important to them in terms of enrolling on a clinical trial that's developed. And within these protocols will be targets for enrollment. And not only will there be targets, but instead of waiting until the trial is finished and saying, well, how did we do? We're going to look each step along the way and say, how are we doing? So we're going to monitor enrollment on the trials. And if we're lagging behind targets, really step up our recruitment of patients from underrepresented groups. Now, the other thing that you may know is that many transplant centers and hence clinical trials are able to provide transplantation primarily for patients who speak English, sometimes Spanish, but other languages are not well represented. And that takes money to translate consent forms. And so the network is going to provide funding to the centers to enable them to translate their consent forms into language of the patient populations they serve. Now, to be an active transplant center in the network, you have to participate well, and you're evaluated on a yearly basis. So the network's going to actually provide double credit to centers to really help them remain and be active transplant centers with the network if they meet their targets for enrolling patients from underrepresented groups. And if anyone has any other ideas, all are welcome. And there's the link that you can send in your own ideas for how the network may help enroll patients from underrepresented groups. So in the next slide, I'll tell you about the other initiative. A lot of initials here, right? This is the ASTCT, or our professional society, and that National Marrow Donor Program would be the NASH. And this was an initiative, and I really love the name, the Access Initiative. And this was formed to address access and outcome disparities in transplantation. The first workshop was held this summer, here in July of 2022, and it focused on three major areas as listed here: awareness, poverty, and racial and ethnic equity. And around each of these focus areas, a working committee was formed. And over the course of 2 days, the working committees assessed barriers, brainstormed, and then on the second day brought forward some proposals for projects in each of these areas that they thought would move the field forward. And as Dr. Kara mentioned, education is really just key. And so for an educational initiative was to really work to help provide resources for physicians in the community. And these are the physicians that are on the front line, that see our patients, that work with patients of underrepresented minorities in their community. But they also need help. Transplantation is a really complex field and has been moving quickly. And we need to help our community physicians to understand which diseases are most amenable for transplantation that should be considered early, as Dr. Kerr was mentioning, in terms of early referral, and make it as easy as possible for them to keep up with our field and to make early referrals transplant centers. And it's just not the physicians or the clinicians or the nurse practitioners that we need to reach out to, is that we really need to be on the ground and working with our patients, patient advocacy groups that are not only disease focused, but think a little bit more broadly, community organizations that are health focused overall. And Dr. Kerr also mentioned these major obstacles and barriers to transplantation that include psychosocial issues, housing, caregivers, financial resources, out-of-pocket costs. And so the task force is going to be performed to really dig deeper into this and to identify resources that will be applicable for all transplant centers for their patients and caregivers, and to invite ideas. We're going to request proposals from all clinicians that care for patients to really try to focus on how we can remove barriers to transplantation for insurance companies. Now, the other thing is that Dr. Kerr and I have worked at transplant centers for many years. And, you know, I hate to admit, but to be honest, is that I'm not sure how I was doing or how my program was doing over the course of 25 years of enrolling patients on clinical trials or even offering transplantation to underrepresented groups. And so instead of each center trying to do their own little piece and figure it out, that the idea is to create health equity dashboards. And you may be familiar with a dashboard, or if you're not, you're familiar with a traffic light. Yellow is caution, kind of take it slow. Red is whoops, not doing well at all. And green is great. And so the idea is to make all those dashboards be green, right? And that each center is meeting targeted goals and really focusing on reaching out to patients with underrepresented groups. So have a dashboard, you tell in real time how your center and how your program's doing. And finally, more of a broader goal is to educate our field. And that's just not clinicians, but that's all the stakeholders that Dr. Kara mentioned, and there are numerous ones about the barriers, and really start brainstorming about removing those barriers for access. So in conclusion, I hope that Dr. Kara and I have explained to you that we think there's some increasing recognition of the challenges and access to transplantation. Those challenges are numerous and they're broad and they're going to require a lot of work. We really believe that there is a need for action, and there's been a call to action to eliminate barriers. And there are new initiatives that hopefully are going to be instrumental in providing equitable, inclusive care. So that with that, I'll close my portion of the talk. And we want to thank AMDS for inviting us, and to Dr. Horowitz and the BMTC and for providing slides about their initiative.
Thank you, Dr. Burns, for the information you shared. I have a couple of questions. So these two exciting initiatives that you mentioned, what do you feel will be the driving force behind or that will ensure success of these initiatives?
You know, that's a great question. And one thing that I failed to mention during the talk is that this is all volunteer time, right? So that we have our day jobs, as all of our listeners may have, things that they do day to day. And this is time that is carved out to really devote to this effort. And so I think everyone is committed to this. So I think that we're going to have a lot of volunteers who are continuing to dedicate their time. But it's also going to be patients and patient advocacy groups working in collaboration. And, you know, 10 to 15 years ago, I performed my first transplant in 1984. And we didn't think about the patient voice or collaborating with patients. What do they need? What barriers are they seeing? And as you mentioned in your portion of the talk, that we have patient perspectives now. And I know that my eyes are open by talking with patients and hearing the issues that they're facing on a daily basis. So I think volunteers working together will get it done.
Thank you. Also thinking a little bit beyond transplant, there's many drugs and technologies that are being assessed for patients with blood disorders. Does the FDA, which is the Food and Drug Administration that approves these new drugs in the US, do they have any interest in improving the diversity on the clinical trials that lead to approval of these techniques?
Yes, so the Food and Drug Administration has for many years had some guidance for clinical trials for industry and bringing their drugs to clinical trials. And it's been fairly basic, and there really hasn't been any metrics or goals. But I think many in our field are delighted to see that in April this year, so April of 2022, the Food and Drug Administration issued new guidance for industry about when they're sponsoring a clinical trial, and many of the BMT-CTN trials, as you know, Dr. Kara, work with pharmaceutical companies and sponsors to test new drugs that may prevent complications of transplantation or facilitate transplant. And so that was followed just a few months later in June of this year with United States House of Representatives passing legislation to help increase diversity. And this was the first major policy change for equity in clinical research in over 30 years. So 3 decades. And so study sponsors are now going to be required to submit a diversity action plan and help meet targeted enrollment for underrepresented minorities for phase 3s and pivotal studies of new drugs. So everyone's excited about this, but also it's the devil's in the details, right? So how are we going to implement this? What resources are going to be needed? But there's a lot of chatter and talk within the transplant field and with sponsors working together to make this happen. So it's an exciting time.
I completely agree. It is exciting time because at least we are now aware of what the problem and what the gap is, and we can work towards trying to address those gaps through a multi-pronged approach. So with that, I think we can end. Thank you, Dr. Burns, and thank you, Alice and team at the AAMDS International Foundation for inviting us to do this.
Thank you. Hi, this is Dr. Burns. I hope you can hear me. Hello, Alice. I'm
Hi there.
present in real time, and if there are questions that anyone has that's listening, I'd be delighted to take them.
We don't have any pending, but is there anything you'd like to add to the presentation, the discussion that you already had with Dr. Kara?
Sure, let me just expand on a couple of things. I know that you did a survey. AAMDS has just done a wonderful job in listening to patients and asking patients, something that we talked about for the patient voice. And there are so many barriers. I was so touched by everyone and their responses for your survey. I mean, many spoke of lack of community physicians' knowledge, and we touched on that a bit. That is such a rapidly moving and complex field of transplantation that we need to assist community physicians in understanding when and how and the best timing for referral. So that is a major initiative. I read about out-of-pocket cost and insurance issues. I just, you can probably tell I'm a senior now. And even in dealing with Medicare, that, as you know, Alice, that Medicare did not cover transplants for myelodysplastic syndrome. And Medicaid coverage differs tremendously for sickle cell disease and bone marrow failure syndromes from state to state. And coverage for transplantation, such a costly procedure, has really been a major barrier for many patients. So I heard the voice, I read the voice, I felt the voice, and we want to continue to work with you as clinicians with our patients and our patient advocacy groups. And I think those webinars and forums such as this is really going to help make a difference in improving equity on clinical trials and access to care.
Thank you. And I think another issue that we encourage patients to inquire about their eligibility for a transplant and early on in their diagnosis, even if it may not be an immediate option, but is that something else that needs to be encouraged by providers, or even if patients don't bring it up, that they do?
Right. So that the National Marrow Donor Program and American Society for Transplant Cellular Therapy each year provide updates. There's actually a mobile app to be used by clinicians to better understand when to refer patients for consultation for diseases. And I think everyone in the transplant field is aware of it, but not those community physicians or non-transplant physicians. And so that is one of the major prongs in the new initiative, to work with transplant centers, to work with their referring physicians, to really be on the ground, to make sure that those community physicians have a really easy access, and also for the transplant physicians to be immediately available for the community physicians. You and I both know that the harder it is, or the many times that you're put on hold or wait for the next physician or wait for the next representative, is so frustrating. And so really trying to make a one contact, the burden should not be on the patient to sort out when they need to see a transplant physician. Certainly we want patients to be educated and have the resources And I provided a couple of links. It's on slide 7. You are looking at the webinar, the NMDP, the ASVCT, the CIBMTR. They have wonderful sites. You can research there if you're not someone that likes to call or talk to someone, but if you are, you look at the site that there's a direct phone number and there will be nurses and patient navigators to help you and get you the resources that you need. So don't be shy about calling.
Thank you. And I've checked again, we have no other questions at this time. So thank you for joining us and adding to the panel discussion as well.
You're very welcome, and thank you on behalf of Dr. Kara and I. We really enjoy working with AMDS. We think that the work you're doing is just phenomenal. We always appreciate the opportunity to meet with you and with the patients that you serve. Thank you.
Thank you.